Welcome, everybody. We are so honored and so pleased to have you with us today. This webinar is a serious effort to try and put two worlds together, Latin America and Africa, through science. It's also a serious attempt to try and reach out to our neighbors, our dear friends in African countries, to share with them the skills and knowledge and pleasure of treating veins and lymphatics. It's my great pleasure to introduce our guest of honor, Her Excellency Mona Omar and Professor Rafat Nega from Alexandria University. Both will be presented in details later. The topic of today is great saphenous vein sparing techniques. This is an exciting topic, controversial topic, which will be presented by really two grandmasters, Paul Pitaloga of France and Monaco, and Sergio Genassini of Italy. I would like to say two words about Sergio. Sergio Genassini is professor at Ferrara University, also professor at Bethesda University, and the founding father and the dynamo of VWIN Foundation. Sergio is passionate about evidence-based medicine, and he's a great team player on a global scale for the purpose of promoting education in the field of veins and lymphatics. We were really inspired by his successful project, Food for Veins, which was our inspiration for this project. But not only this, actually Sergio was the cornerstone of this project. He made himself available all the time, day and night, from very first moment until now. So we are very thankful to him. Professor Oscar Bottini, all the world knows his many contributions professionally and on humane aspect. Professor Bottini is very busy in his practice in Latin American societies, in the UIP, in VWIN, and many other commitments. And despite his multiple commitments, Professor Oscar Bottini spared no effort and no time to work with us to build this bridge between Latin America and Africa. So thank you, Oscar. I'm really honored to have with us our distinguished panelists who are going to be presented one by one later in the session. Of course, this could not have been possible without the unconditional sponsorship of our main sponsor, Servier, and our sponsors, Ablate and Biolytic. So thank you for them. Finally, I would like to announce our award. It's $500 toward the flight, plus free registration to the World Expo of Dubai, which will be held in January 2022. It's going to be awarded for the best question or the best comment. So please write your questions. We will not have time to discuss all of them, but they will be recorded and filtered later. Now I'll leave the word to my dear colleague, Dr. Wasila, who is my long-time colleague, and also she's the real engine and the real dynamo behind this work. Dr. Wasila? Dr. Wasila, go ahead.
Oh, thank you. Thank you, Professor Bishara, for such nice introduction. And I'm really glad to be a part of this perfect project, really communicating both continents and with some highlight on our dear continent, Africa. And now I'm really and truly honored to introduce Her Excellency Ambassador Mona Omar. Her Excellency, she is former Assistant Minister of Foreign Affairs for Africa, member of the Panel of Eminent Persons in Africa, and member of the Committee of Human Rights of the United Nations in Geneva. And the best part is we call her Mama Africa. Why? Because her great endeavors and great achievements to our dear continent, Africa. Your Excellency, the podium is yours now.
Oh, thank you, Dr. Wasila. Thank you so much for this so nice presentation and introduction. I would like to start by addressing my very short words to the dear speakers, the panelists, and also the dear audience. I would like to ask you all, is Africa really a sleeping giant? Do we really have the capacity to fly in Africa? How can we change the image of our dear continent so as to make it rise and take its well-deserved position among the most developed continents? Do you know how? Throughout the years I have spent in the African continent as ambassador and as Deputy Minister of Foreign Affairs of Egypt, I became very much convinced that only through sciences and technology, through the development of our infrastructures, that we will be able to achieve our aim. Healthcare, education have to be targeted by each one of us. And in this difficult time of COVID-19 spread, participation in training and learning webinars is very, very important. Venous and lymphatic diseases are very much needed fields of medical services and education in Africa. Our African continent is largely deprived of advanced education in this field. Through this webinar, I hope we can reach out to all our African medical specialized institutions for a knowledge transfer and experience exchange, so we can bridge the existing gap in this vital field. Dear all, I'm sure that together, armed with knowledge, sciences, and education, we will wake up the giant. We will rise and change the image of our dear continent. Thank you so much.
Thank you, Your Excellency, for your nice words. It's my pleasure to introduce Paul Pitaloga. Everybody knows Paul. Paul of Riviera Veins Institute is really the creator of asphalt technique, of the ascending theory of reflux. Paul visited Egypt in 2014. This was actually a landmark because he not only conducted a very successful conference, but he introduced modern vein therapy to the Egyptian vascular community, which was really a landmark in our practice. It's my pleasure to introduce Paul. Paul, please go ahead. Dr. Pitaloga, please unmute yourself. Right. Unmute yourself and share your screen.
So good afternoon to everybody. Thank you very much for this very nice invitation. It's my pleasure and my great honor to participate to this first Saturday Night Vein Talks. My disclosures. As you may know, for decades, the gold standard for the varicose vein treatment was ligation and stripping. And to say the truth, all along the 20th century, there was no innovation for the superficial venous insufficiency treatment. But approaching the new millennium, everything began to change with the emergence of a maelstrom of innovative techniques such as radiofrequency, endovenous laser, foam, steam, mechanochemical ablation, and more recently the glue. All of these techniques having in common to be minimally invasive by endovenous treatment with a percutaneous access. You probably know this RCT of Rasmussen, which reported, as many others RCTs, similar midterm results and less side effects for the endovenous technique compared to the traditional surgery. It led the American guidelines as soon as in 2011, followed by the European guideline in 2015 to give to the endothermal ablation the highest grade of recommendation in preference to surgery. And that was a true disruption in the way of treatment for varicose veins since decades. But was it the true revolution, or was it the beginning of a global change for the management of varicose veins? Indeed, at the same time of the technical revolution, there was a revolution on concept. we have got two big news from this experience of endovenous techniques. First, we have got that eye ligation is not necessary because eye ligation is not performed in the endovenous technique without consequences. And the second big news that we got is that the saphenous removal is not essential because the frequency of varicose vein recurrence is still high even after a successful saphenous ablation. Therefore, without these two cornerstones, eye ligation and saphenous removal, the traditional descending theory collapsed. And we called into question the systematic saphenous ablation, and we highlighted the saphenous preservation. We have published for the first time 15 years ago in the French Journal of Phlebology the first paper about ASVA based on the ascending evolution theory of venous insufficiency, which enables to limit the treatment to the tributaries in order to have hemodynamics and symptoms improvements. Because in this concept, the varicose veins are at the origin of the hemodynamic trouble. It's also a mini-invasive surgical technique performed under tumescent local anesthesia by atraumatic phlebectomy through microincision and guided by a very precise pre-op ultrasound skin marking. We have published in 2009 in GVS this result with such improvement of the saphenous hemodynamics and symptoms, and with a significant reduction of the GSV diameter. And this last decade, other authors have reported their experience about ASVAL, and all the papers published reported after treatment of the varicose reservoir a significant abolition or reduction of the saphenous reflux, a reduction of the saphenous diameter, and more importantly, an improvement of symptoms and quality of life for almost all patients treated. These papers also reported their own criteria for the preservation of the saphenous vein. It is why in 2017 we have published in the Vein magazine all the criteria published for the preservation of saphenous vein, and we split these criteria in major and minor criteria according to their significance and the number of papers citing them. And we determined that at least one major and one minor criterion should be associated in order to perform an ASVAL, and also that the more criteria there are, the clearer the indication of ASVAL. We have integrated this criteria in our daily practice with a score that we call the CIA score. We have implemented this score in our database, and the first evaluation that we have made showed that a score above 4 allows saphenous preservation. This score is obviously, there is a study about this score in progress. But following this new strategy of treatment, we went one step further. With this question, is the elimination of the saphenous reflux the main outcome for the evaluation of the treatment of varicose veins? In this study, in which we followed more than 100 limbs at 5 years, we observed that all along the follow-up, a significant proportion of patients had a persisting GSV reflux without any clinical significance. Moreover, we have published in 2018 the 10 years outcome of ASVA. In this study, a Kaplan-Meier analysis showed a pretty stable evolution of the freedom of GSV reflux, which were at 64.4% at 10 years. But at the opposite, we reported the decrease of the improvement of symptoms along the follow-up from 87.5% to 69.9% at 10 years. And also the aesthetic benefits dropped from 93% to 65.7%. In the same way, the freedom of varicose recurrence decreased from 97% to 68%, and the freedom of surgery dropped at 76.7%. the analysis of reduced surgical procedure during the follow-up showed that a secondary saphenous ablation was performed in only 9 cases out of the 24 reduced surgery, and that redo as well was performed in the remaining 50 cases during the 10 years of follow-up. One of the most important observations of this paper is probably the discordance of the Kaplan-Meier curves between the continuous deterioration of the clinical results and freedom of reduced surgery compared to the stability of the GSV hemodynamics. Indeed, when we compare the evolution of the improvement of symptoms, improvement of aesthetics, freedom of varicose vein recurrence, freedom of reduced surgery, with the freedom of GSV reflux, this discordance of curve shapes is obvious. And this discordance can be explained by the fact that the evolution of venous insufficiency follows the natural evolution of the disease on the tributaries, mostly independently of the saphenous reflux. The limited importance of the saphenous reflux is also illustrated by the limited number of secondary saphenous ablation during this 10-year follow-up, with redo as well in the wide majority of the cases. And it also means that the main criterion for redo surgery was a clinical criterion more than the GSV reflux. That has been reported also by Biemans in this paper about Asval, where he wrote that we should not focus only on the saphenous reflux, but also take into account the patient's symptoms, and that the presence of reflux does not necessarily correlate with the functional impairments or the clinical disease. We can even look beyond this new strategy of treatment and imagine what might be the future for the treatment of varicosities. In my opinion, the first way for the future to consider is to optimize the treatment of the reservoir. And it should be achieved by a directional carrier that will optimize endovenous progression, enabling to perform all along the tortuous varicose tributaries and endovenous varicose reservoir ablation. That is the trip-away project that we have begun to develop. The second way to consider for the future is the reinforcement of the vein wall by the venoactive drugs, because there is an increasing number of evidence that venoactive drugs are efficient, targeting the inflammatory cascade of chronic venous insufficiency and improving the venous tone. In conclusion, for the future, I think that adding an endovenous ablation of the varicose reservoir with a remodeling of the saphenous vein by venoactive drug is changing the strategy from a destructive strategy to a reconstructive approach, more in accordance with vascular surgery philosophy. Thank you very much for your attention.
Very nice talk, Dr. Pitaloga. Thank you for giving us your 10 years experience. It's really, really fantastic. And Dr. Asila, would you like to present the panelists, please?
Yes, Professor Bishara. Now, I'm really honored to introduce someone who doesn't need, in fact, any introduction. Professor Roberto Simkin. Professor Roberto Simkin, Professor of Vascular Surgery, University of Buenos Aires. He's past president of the International Union of Angiology, past president and founder of the Latin American Venous Forum. Professor Simkin, now you can address your question to Professor Pitaloga, please.
Thank you very much, Wasila. It's a pleasure to see you. Congratulations, Paul, for excellent presentation. We have practiced these techniques for several years, and very good results in all the patients. My question, I like it, make it 2 questions, very small questions. In the cases of recurrence, they observe whether the diameter of the saphenous vein was the same at the prior surgery. This is the first. At the second, what treatment is indicated for the cocket perforated vein more than 5 millimeters?
So for the first question, it depends when we see the patient in follow-up. If in this study, we followed up very closely the patient. So It explains why we have so little number of secondary saphenous ablation. Because we follow the patient very closely, we see the recurrence very early, and therefore the diameter of the saphenous vein was not very big, which allowed us to do a new ASVA. In the 9 cases of patients for which we have done a secondary saphenous ablation, the diameter had increased and was above the limit for which we can preserve the saphenous vein. For the second question and the perforators, it's a very good question. It's not a question of diameter, in my opinion, because a perforator has the same behavior than the junction. The reflux can disappear if you treat the reservoir. The only, for me, the only indication for treating a perforator is when you have a skin change at the same place of the perforator. That is the only, for me, indication when you have a C4 to C6 patient with a big perforator. That is, for me, the indication for another thermal ablation of the perforator. Otherwise, if you treat the reservoir, you suppress the superficial reflux, and most of the time, the reflux on the perforator, as it is on the junction, disappears.
Thank you very much, Dr. Pitaloga. Excellent presentation. It's a good pleasure. And Vasila, thank you very much. Dr. Rashad Bishara, thank you very much for the kind invitation to participate in this excellent meeting. Thank you.
It's our honor. Dr. Asila, would you like to present the second panelist, please?
Our second panelist is Dr. Ahmed Hassan Bakr from Egypt. He's vascular surgeon at Asyut University, an active member of IVLA, Egypt Africa Vein Lymph Association. Dr. Bakr, you can address your question to Professor Pitaloga now, please.
Sure. Thank you, Dr. Wasila. Thank you, Dr. Rashad Bishara, and all the members of the organizing committee for such great efforts. It is much appreciated. Thank you, Dr. Pitaloga, for your exceptional presentation. And actually, that is the beauty of this job, that we search for the hemodynamic question for every case we treat and try to solve it. Your work is based on the ascending theory that it first starts with the varicose reservoir and then comes the incompetent or the refluxing trunk. So you treat first the most distal, the varicose veins, and wait for the trunk to get improved subsequently. And that debates actually the classic retrograde hemodynamic evolution of varicose veins. In your work and in your experience, do you shift between the two, or all the way you go in the stick to the ascending theory? Second question, okay, following your limits for the great saphenous vein intervention to ablate it, do you have, because I've noticed in your published article that the mean diameter was 7.8 plus minus 0.25. So do you work on more than 10 millimeters GSV or not? Thank you very much.
Two very good questions. Thank you very much. For the first one, as you know, if you are working on veins, the venous system is everything than simple. It's not simple. It's complicated, and you have no one explanation for everything. It doesn't work like that, because the venous network is a chaotic system, and one variable change, all the system changes. What we observed is that in most of the cases, the evolution is ascending. But first, you have patients in which it's not true. When you have a GSV reflux without any varicose reservoir, without varicose veins, you cannot explain the reflux on the GSV by tributaries, because there is no or very little number of varicose tributaries. And the second example is when the evolution is at a very late stage. The evolution is also descending. When the saphenous vein is too damaged, there is a descending evolution which is added to the ascending at the beginning. So there is a stage where you cannot preserve the saphenous vein because the saphenous vein cannot recover after the removal of the varicose reservoir. And it is why the ASVAL method is complicated to apply. Because when you ablate the saphenous vein, when you assess a reflux with ultrasound, it's very simple. You ablate it, you have just to choose the way how to ablate it, surgery, the heat, the glue, or the foam. When you have to determine if you can preserve saphenous vein or not, you need criteria. And you need there is a learning curve. You need to learn how to manage these criteria. And it is why, because you cannot have 10 years experience to decide, we have set this score. And this score, and I will answer to the second question, by the way, integrate not only the diameter. The diameter is one of the major criteria, but not the only one. Because if you have very short reflux, for instance, 10 millimeter diameter, but afterwards your saphenous vein normal, and this the part of vein which is very dilated, it's some centimeters. That is not a contraindication of asthma. There are also many other criteria. These criteria have been published, and it is why we have set this score, which could be used by everybody in order to have an idea if this patient is a good indicator for ASVAL or not. And I guess that this score, the study about this score can be published in the coming month or the coming years, but we will do that.
Okay, thank you.
You're welcome.
Professor Oscar Bottini, would you like to present the next panelist, please? Dr. Wasila, would you like to share your screen?
Thank you. Let me introduce Dr. Mandy Wong. It's a Canadian Society of Phlebology president. Dr. Mandy.
Hello. Thank you for asking me to participate, Dr. Pitaloga. I've been a fan of the ASVAL technique for many years, but where I live, there's no coverage for phlebectomy, so the patients would have to pay privately. So instead of phlebectomy, I've been using foam sclerotherapy, and I'd like to know what your thoughts on doing that is.
So thank you for your nice comment first. That is a problem in many countries. For instance, in the US, the coverage of phlebectomy is not very good, and it's a true obstacle to perform the technique. I think that foam can give some results, but I think that foam is not so good that surgery. Why? Because when you do a phlebectomy, you control very precisely where you put your ligation, what is the veins that you are removing, and it's more precise. When you inject foam, it's very difficult to control the progression of the foam, and sometimes you put some foam in the saphenous vein. So I think that surgery is better. And in addition, I have some question about the foam, because the foam is initiating an inflammation, and the inflammation direction, inflammatory reaction is different from patient to patient. So some patients have very high reaction, the other one not so much. So it's something that we don't control. The progression of the foam and the reaction on the foam you don't control as well as you do with the surgery. It's why I think that the best technique for ASVAL is the surgery. I know that it's not so easy to do, and you need a learning curve, and it is why we have initiated this 3BOE project for an endovenous ablation of the pituitary, which is not possible so far with the material that we have for the endovenous ablation.
Okay, thank you very much.
Thank you. Dr. Wasila would like to introduce Dr. Ahmed Gawish, please. Please unmute yourself.
Dr. Ahmed Gawish is the very active member of IVLA. Actually, he is the vice president of IVLA, the Egypt, Africa, Vein Lymph Association. He's a vascular surgeon from Alexandria University and member of the engagement working group of the UIP, Union Internationale de Phlebologie. Dr. Gawish, now he will moderate a box of questions and answers. according to the most liked question. Dr. Gawish, please.
Thank you, Dr. Wasila, for your kind introduction. I'm really honored to be among this great group of panelists. And we enjoyed very well the talk of Dr. Pitaloga. Let me highlight for the audience that we are having, they can ask any questions in the Q&A part. And most questions, we'll take some questions here, and the other questions will be answered later by the speakers, because for the sake of time. So let me start by directing two questions to Dr. Pitaloga. Is the outcome of ASVAL, that's a question from Hugo Navas, is the outcome of ASVAL method related to the diameter of the saphenous veins? And can we say that the main indication of ASVAL is a case with competent terminal or pre-terminal valves and not very dilated saphenous veins? That's Dr. Pitaloga.
It is the same answer than the previous question. The diameter is one criterion. It's a major criterion, but not the only one. I have very, very good example about that. That is the same answer that for the junction. You have anterior accessory varicose tributary, very big one. You have a reflux at the junction with very dilated junction, but only on the junction. If you remove the anterior accessory, you get a disappearance of the reflux in 100% of the cases. The same thing for a very short reflux at the thigh with big varicosities. If you do it, the reflux disappears. So you have other criteria, such as, for instance, the reflux elimination test, with which during the pre-op assessment, by compressing the varicose tributary, you can see after the squeezing maneuver if the reflux disappears. It's a very good criterion to determine if you can preserve the saphenous vein. The age is also a good criteria. The absence of the nullipara patients before pregnancy, it's better to preserve the saphenous vein, because when you remove it, the recurrence are worse. So there is many criteria. And it is why I think that it's very important that we publish this score, because this score gathers all the criteria in something which you can use in your daily practice. I know that is one of the limits of the people to do ASVAL, is that you have to select the patient, and your fear is to fail with very fast recurrence, because you didn't remove the reflux on the saphenous vein. But we are working on that.
Okay, thank you. Is there a time for another question, Dr. Rashad?
We are 3 minutes late, but we'll take another question, yeah.
Okay, so another question from Aliber Francisco says, what about only treating the perforating veins and not treating the saphenous vein?
Again, the perforators are a communication between the superficial and the deep system, as the junction are. So we have the same way to treat the communications between the deep and the superficial. We have reported that this communication, when there's a reflux between the deep and the superficial, when you remove the reflux on the superficial tributaries, this reflux disappears. The only way to explain that the reflux from the deep to the superficial is at the origin of the superficial reflux is when you have a deep reflux. If you don't have a deep reflux, I cannot understand how you can explain that the deep reflux creates a superficial reflux. At the opposite, the superficial reflux can create the reflux on the perforator by a filling effect. And when you remove the reservoir, this reflux most of the time disappears.
Thank you.
Okay,
Dr.
thank you very much.
This was fantastic, really. And now it's my pleasure to introduce our second speaker, Professor Sergio Giancini, professor at Ferrara University in Italy and Bethesda University in the United States. Professor Giancini is going to talk about evidence based behind the great saphenous vein sparing technique and future directions. Sergio, please.
Thank you so much, Professor Bishara. Thank you to all the friends from Africa and Latin America. But first of all, I'd like to thank Mohamed Abdelaziz. I don't know him, but I saw that he just made a question that gives me a perfect corner kick for this topic, because he was asking, Shiva, or should we go with Asval? And there is this attitude around the world of feeling we are kind of competitors, as you can see from my face expression in this meeting. But in reality, the real feeling is the one of friendship and teamwork in co-working together, in understanding how we can apply at best saphenous-sparing approaches in an evidence-based way for future directions aimed to improve our patients' treatment. I have no conflicts of interest to declare, particularly because this talk is all about physics, about those laws of physics ruling the drainage back to the heart. Of course, it's not the task of today to cover all of them, but an important one I want to mention is the Poiseuille law, that in a very simple way is stating that if we want to create a flow from a point A to a point B, or a reflux from a point B to a point A, we need a pressure gradient. And as perfectly depicted by Professor Pitaloga, this point A can be a leaking point, for example, an incompetent saphenofemoral junction, and the other point is the reentry perforating vein. So that we have a golden rule. Whenever we have a reflux, we must find the reentry point. That can be, for example, along the GSV trunk in this example, or along an incompetent tributary. Of course, we must know our leg in terms of the venous roads of drainage. And we could say in a simple metaphoric way that we have a deep venous highway, a saphenous freeway that reminds us the Egyptian eye in honor of this project, and also many tributary roads and perforating streets that are connecting the systems. We published in 2017 that there is indeed a velocity gradient that physiologically is changing from the surface toward the deepest compartment. And we also published that this velocity and pressure gradient is subverted in case of reflux. So our aim is to apply the laws of physics to simply act on this pressure gradient to restore a normal drainage. And as perfectly said by Paul, it is extremely difficult. So we have to study properly rather than just going there and ablate something we don't like without understanding it deeply. So should we ablate or should we not ablate? This is really an analytic question, particularly for those countries in which an ablation is required in order to get a reimbursement from the insurance. But I think that is also an important question, the one we make to ourselves every single day when we are in the operating room and we see that there is a perfectly functioning GSV with an incompetent tributary that is clearly pathological. As I think it's really important, we offer the brand new techniques to our patients, offering always a bigger mini invasiveness. But at the same time, I think it's our responsibility to clearly state the difference between the technique compared to the strategy, because we can use innovative techniques with an old ablative strategy, the same strategy described by Albucacis of Cordoba in his first surgical stripping description in a textbook, which reminds me of giving brand new weapons to the army, instructing the army to move always in the same direction. The direction of the guidelines that is going back to 2011, when we were already receiving the recommendation of favoring endovenous thermal ablation over traditional surgery, but as specified in the guidelines, not because of the better recurrence rate, rather because of their mean invasiveness. And this actually remained the same if we look at the brand new guidelines from 2020, where again we have the overlapping recurrence rates of endovenous thermal ablation and new devices coming in with actually recurrence rates that are actually less favorable than the one of the endovenous thermal ablation, but of course more mini-invasive. Back in 2015, Cochrane reported that there is an opportunity in reducing the recurrence rate by applying hemodynamics rather than simply ablating. And I really don't want to get into the Shiva and Asval talk because I know on my skin the typical American face expression I get when we start talking about these fancy European theories, and also the Russian friends, as you can see from our friend Dennis, in honor of the good time in which we were talking live about these things. So I really want to focus on the technique and the strategy rather than Shiva and Asval, who demonstrated to be extremely valuable option. But to be honest, I don't think it's Shiva or Asval, because if we go back to 1971, already the Fagan group was talking about the reversibility of the saphenofemoral reflexes. Both Shiva and Asval demonstrated that we can reduce the caliber of the GSV back to a normal, restoring a proper drainage. Shiva demonstrated also with platysmographic parameters that it is possible to restore a normal drainage. But of course, I'd like to point out that here in this study, the follow-up is pretty short. So it'll be interesting to look at longer follow-up. But it is also true that it has been demonstrated that saphenosparing works also in advanced cases, as you can see in this answer, patients treated by a saphenosparing approach. For sure, it is interesting to notice that at 10 years, also Shiva reported a better result in terms of reflex disappearance. And even more interesting, considering we have also Professor Taher, that is one of our big figures, particularly for the ultrasound. According to the study of Pares, of course, Shiva was performing better than the stripping in terms of the recurrence rate. But even more interesting, if you look at the group performing a stripping with or without a preoperative duplex mapping, there was no difference, meaning that if you have to remove everything, doing the preoperative mapping is not really making a difference. This is another publication of our group that is focusing on the terminal valve analysis, showing that if one of the two maneuvers, squeezing or Valsalva, is actually negative, despite an incompetence of the saphenofemoral arch, by a simple ligation of the incompetent tributary, or we could also perform an Asval, and we can discuss about this, we are going to have a 3 years follow-up, absolutely competitive results in terms of recurrence rate. In this other investigation of our group, we focused on the iliofemoral tract, so the valve above the terminal valve, showing how it represents a risk factor for recurrence of the saphenofemoral junction with an odds ratio of 4.8. In these specific cases, we still perform surgery, but not the traditional quite large incision, mean incision with a titanium clip position flush on the femoral junction, always with a saphenosparing approach. And we demonstrated that in this way, we have a favorable odds ratio in terms of recurrence rate with competitive results at 5 years follow-up. If we look at the most recent literature, we see that the meta-analysis coming from Guo in 2019 is still favoring a saphenosparing approach compared to the traditional ablation in terms of recurrence rate. But I really like to focus on the topic of this slide. Are we sure we are looking at the correct results? And I really appreciated the talk of Professor Pitaloga because we didn't agree before, but we are touching basically the same points. It's not just about the occlusion rate or the recurrence rate. It's mainly about the patient's reported outcome, the clinical success, and maybe also the cost effectiveness. Of course, we have to offer always more mini-invasive procedures to our patients, but we also have to look at the quality of life. Now, it's interesting to notice that with a short follow-up, but endovenous and thermal ablation with a total ablation of the segment actually reported to be effective in the quality of life control. I don't know the personal opinion of Paul, and I really look forward for his comment on this, but I found that also Asval was reported with an endovenous approach, and I appreciate that the authors were focusing on the quality of life. Back in 2013, we started to apply a modified Shiva strategy, performing a segmental ablation only, sparing the remaining part of the GSV trunk. And some months ago, we also published the results of the comparison between endovenous laser ablation and radiofrequency ablation in terms of recurrence rate. And of course, we will need a longer follow-up, but it is interesting to see that the quality of life significantly improved. I really suggest you to enjoy this wonderful reading of Professor Lurie, What We Know and What We Don't Know in Venous Hemodynamics. I strongly believe we don't know so much of the relationship between the micro and the macro aspects of the venous disease. We know that there is a vicious circle, we know that there is hypertension, but at the same time, we don't know, very probably many times, that already starting with the symptoms, we have a decrease of the functional capillary density looking at C0A versus C0S. So it really seems to me that we have a domino effect that is starting from the very beginning, for which it is fundamental to have a 360 degrees knowledge of the disease. I really appreciate saphenous sparing, either ASVAL or Shiva, because it's leaving there a biobank that is your own patient's saphenous vein, where you can go back and harvest, for example, blood sample, as we did in this investigation, where we demonstrated that the inflammatory biomarkers can be significantly reduced after a Shiva procedure. I kindly disagree with the Shiva colleagues who are saying that we should spare the GSV because it's the perfect bypass conduit. We have other conduits we can use. Maybe it's the best one, but luckily enough, also the vast majority of my patients, meaning everybody, all my patients, luckily enough, didn't need that along the time. So rarely it happens to use it. So I wouldn't use that as a main reason to spare the GSV. My main reasons to spare it is because we are not one size fits all. So I think we should always offer the tailored hemodynamic approach. Of course, we have to improve the recurrence rate because it's not possible that all these bright minds in this webinar are not able to improve the results that have been the same since the time Albuquerque of Cordoba. But we should also look at the quality of life and maybe in the near future also the time effectiveness of the procedure and the cost effectiveness. Quoting a founding father of the UAP, Glauco Bassi, at that time, 50 years ago, the phlebologists should have known surgery, compression, and sclerotherapy. Now, of course, we must add the innovative devices in the picture. I actually include, again, mini-invasive surgery, but nothing will change if we don't keep a strategy in the middle and we don't improve that one. So before asking whatever brand new device that is coming out with the new fashion of the moment, I would ask for a brand new Doppler probe and for a proper assessment of the hemodynamics. In conclusion, since in life it's not just where you go, but also who you're traveling with, say that you're landing in Rome and as I wish you will come to visit me in Ferrara and you will find a DVT block around Florence. You can always take the perforated road on the Apennines, travel on the Great Saphenous Freeway you spared, and join me in the University of Ferrara where I'll be waiting for you. And where we'll have the chance also to dive into this kind of literature we published after the last winter meeting in 2019, for which I'd like to deeply thank all the colleagues also from Africa involved in the effort. As I like to deeply thank all the societies who are gathering together for this global call about fake news in venous and lymphatic medicine. There is a dedicated website where you can report eventually encountered fake news in our field, and we will have the chance to report that in a Delphi consensus document presented during the Expo Dubai 2022. But not, of course, before having enjoyed this wonderful trip on the Latin America and African bridge, for which I deeply congratulate the organizer. Thank you.
Thank you, Sergio. It's really amazing how much information you can put in such little time. And thank you for this respectful time. I wish I could ask Dr. Pitaloga to comment, but really we are late, so we have to proceed. So Dr. Osira, could you please present the panelists?
Oh, yeah, yes, but not before to thank Professor Giannesini for such an excellent talk, very informative and very comprehensive. And I think it will stimulate a lot of questions, Sergio. Thank you very much. And now I will introduce someone who really does not need any introduction, Professor Evgeny Shaidakov from St. Petersburg, Russia. He's the professor of cardiovascular surgery at St. Petersburg University, presides so many structures and course, and member of the International Committee of the American Venous Lymphatic Society, UIP Education Committee advisor, and he ran a very interesting venous forum in St. Petersburg. And I would like to encourage all of you to really join his meeting there. Professor Shaidakov, the podium now is for you.
Thank you very much. Dear Rashad, dear colleagues, it's a great honor for me to be a part of this discussion. It's a very interesting topic and fantastic presentation, Sergio. It's a very, very helpful procedure to preventive and when preserving operation. I have my own experience in 25 years, long-term results 50-50, but it's a very important question. At first, I would like to say thank you very much for authors of this book. I must say that not many specialists in Russia, not many centers, only few centers understand this kind of operation and use this operation in daily practice. For many years, I didn't understand this operation, but I read this book 2 times and I understood hemodynamic effect and the techniques of this operation. And I changed my technique and changed my operation, Shiva as well, last 2 years in daily practice. Very important question. I would like to translate this book for Russian language, some chapters to understand new generation of Russian phlebologists to understand this method. Different because from the one side, it's a hemodynamic effect. It's very helpful procedure for early stages of varicose disease. But for another side, it's a chronic venous disease. It's a chronic process. So we have a recurrence veins and we have a valvular insufficiency of this operation and incompetence of great saphenous vein. My question, short question. Sergio, what do you think? What's your opinion? Maybe it's necessary to use extravasal or intravasal valvuloplastic correction to support saphenofemoral junction, the proximal valve of great saphenous vein. And maybe it's necessary to use this kind of operation to all operation as well. What do you think?
I think it was better the last question you made me, if you should have pasta or lasagna, because we were discussing about hemodynamics in Italy last time and I learned a lot from you as well. Jokes aside, the reason why that question would have been better, because that question had an answer. This one has no answer based on the evidence-based data. My comment is that in reality, the group of GUO published just last year that up to 82% of the leaking points are not coming directly from the saphenofemoral junction, but from other leaking points. And as mentioned by Professor Pitaloga, a simple finger during a reflux elimination test, compressing the incompetent tributaries is able to control the reflux and normalize the flow. Having said that, I think that there is a potential in the external or internal valvuloplasty, but we have seen along the years how difficult it is to really perform it technically in a way that is producing valuable results. I think we should really try to avoid over-treating our patients, because we have seen that already at C0S we have a capillary dysfunction. And the most drainage we keep, I think, the better inflammation control we can have. So I think it will be interesting to look in the future, but I don't think we have evidence-based data to support or not external valvuloplasty in this moment or internal valvuloplasty. But it is interesting to spare and study.
Thank you. Thank you, Sergio.
Thank you so much, Eugene.
Dr. Wasila?
Thank you, Professor Giannisini, Professor Shaidakov. And now it's really an honor to introduce a good and important part of our webinar, highlighting our dear continent, Africa. Professor Marcus Foucault, he represents Africa in the board of panelists. He is the Chief of Vascular and Thoracic Surgery Unit at the U1D General Hospital in Cameroon. And if I can read the list of awards of Professor Foucault, I will stay in my chair for tomorrow. So he has been awarded International Union of Phlebology Servier Research, American Society for Vascular Surgery, American College of Surgeons, German Academic Exchange, and le prix de la Conférence Médicale Nationale du Cameroun. Now I ask Professor Foucault to address his question to Professor Giannisini. Marcus, please.
Thank you very much, Dr. Wasila, and warm greeting to everybody from Cameroon. I'm very grateful to be part of this panel and part of the bridge between the two continents for venous diseases extension. My question will be very short. From the presentation of Professor Giannisini and even Professor Pitaloga, there are so many advantages to develop and to implement strategies to spare the greater femoral vein. Why is that those techniques to spare the greater femoral vein are not widespread in clinical practices around the world? What's the problem at the end? Since there are so many advantages to spare the greater femoral vein, but practically most hospitals, most people are not practicing it or are not concerned about that really. What is the blockage?
Outstanding, a really practical question, Professor Foku. I see multiple reasons for this. The first one goes with the publication of Milone, who was demonstrating that if you are not able to perform properly a saphenous-sparing procedure, you'd better not to do that. The metaphor is really simple. If you want to create a custom-made suit, a tailor-made suit, you have to have a good tailor. If not, it's better to get a pret-a-porter jacket. And that has been demonstrated. Another reason is purely public health, meaning if you have to be reimbursed, you are going usually with a procedure that is going to be reimbursed. This is preventing, in my opinion, a little bit the possibility of studying and gathering together like we are doing together on both sides of the Atlantic on the possibility of stopping not just the reflux, but also maybe the evolution of the disease, a question we don't have an answer yet about the progression.
If I can say one word about that, I think that one of the main reasons is also for ASVAL that a lot of people are doing that. And there is no teaching center for that. And you have to have some experience because ASVAL is a little bit more simpler than Shiva in the concept. You just have to do phlebectomy at a good place, but you need to learn. And there is no place to learn that. That is the main problem. It's why we are thinking about teaching teachers in order to spread this technique, which is not expensive and which has many advantages, as you have very kindly highlighted, Professor Foku. Thank you.
Thank you very much.
Dr. Wasila, please introduce Dr. Ahmed Gawish.
Hello again. Hello, Sergio.
Hi, Ahmed.
Hi, good to see you. Nice presentation. Thank you for it. Talking about tailors, we have some questions for tailoring the ASVAL technique for such a case. There is a question from Annalise Rodriguez. Says, in a patient with incompetent terminal valve and competent pre-terminal valve and has an anterior saphenous vein incompetence with a competent great saphenous, would you pick Jiva or ASVAL with preservation of saphenofemoral junction?
The first thing I would do is putting a finger on that tributary and see if there is a reflux suppression on that. The case is pretty rare, I have to say, according to the protocol we established in our clinics following the publication on phlebology we did on the ilofemoral tract. If there is an incompetence of that tract, we have up to 5 times the risk of developing a recurrence at the junction. So I would think twice before just leaving the incompetent terminal valve there, because the hydrostatic pressure you are going to develop there is significant. So in that scenario, I would honestly stay safe. And because of course we can play with the hemodynamics, but this would be quite too much of playing, I think. And then I would put a titanium clip flash on the femoral because of the ilofemoral incompetence. And then I would treat either with ASVAL or like a ligation of the anterior saphenous vein, or if you want, you can also have a segmental shrinkage of that tract.
Okay, thank you. Dr. Rashad, do you have time for another question, or we have to conclude?
Rashad, you're muted.
Just one more question.
Okay. One short question. Can we apply the ASVAL in relation to how we apply the ASVAL to the relation between pelvic congestion syndrome and great saphenous vein?
I can answer to that, but if you want, you have Paul here, as you prefer. What do you want to ask?
It's a very good question, because the pelvic syndrome is a new trend but for the explanation of varicose veins. And my opinion on that is very clear. I never treat, I don't talk about the pelvic congestion. I'm talking about the varicose vein on the pelvis. When a patient has a varicose vein on the pelvis, I think that the only indication to treat that, to treat the pelvic reflux, if there is a pelvic congestion syndrome. I never treat the pelvic reflux if there is only varicose veins. I treat first the varicose veins because I'm very cautious about the relationship between the pelvic reflux and varicose veins on the limbs. For me, there is no evidence, and it's a pretty invasive. You have to put some cord. It's very expensive, and for a woman who have no symptoms on the pelvis, I don't treat the pelvic reflux because if you pick up 10 women in the street, with pregnancy, you will see a lot of varicose vein around the uterus, and it's why you need symptoms to treat that, in my opinion, because that is a new trend to first treat the pelvic reflux and afterwards the varicose veins, with the same idea that is coming from upwards. In my opinion, there is no evidence.
If I can comment on this, I think this is the perfect example of what varices is for real. It's the natural defense of the organism to venous hypertension. So I totally agree with Paul that if there are no symptoms, that's the natural reply. Of course, there could be also an aesthetic concern of the patients. We published on Phlebo Lymphology that if you have a VAS of up to 5 and you control the leaking point by sclerotherapy, though we didn't do by ligation, that has been described in Shiva, but I actually don't practice that because I prefer in those cases to reach all the tributaries by foam. You can have a satisfying results of 64% at 3 years follow-up. So not so high in reality, but still present, and you can redo foam in case.
Excellent. Well, time has come to conclude the meeting. I will just take a few more minutes. So I will present again our great professor, Sergio Genesini, who was the real cornerstone behind the success of this meeting. And if I may ask you, Sergio, to wrap up the meeting. Thank you.
Sure. So if I can share the screen, I just prepared a few slides. I think the take-home messages, with all the due respect for Professor Pitaloga, I hope I'm touching the right point. I would say that the recurrence rate is the same despite the technical innovations as we have seen. So we need new strategic advancement as well as supported by valuable long-term evidence-based data. Reflux recurrence per se is not the main clinical outcome, and venous active drugs may play a role in future practice. If I have to wrap up my concepts, I'd say that basically we mirrored each other, and it's a very beautiful, I think. It's clearly that as Val and Shiva are not competitors, we are working in the same direction. Technique is different from strategy. Saphenous sparing can reduce the recurrence rate. Saphenous sparing can be performed also in an endovenous approach. And the recurrence rate is actually not everything. We have to talk about also microcirculation, quality of life, and cost. I'd like to have just a final comment. This is the situation I see currently in the modern webinar scenario after COVID. There is an uncontrolled proliferation of webinars and everybody's trying to promote his. So I'd like to deeply congratulate this initiative of Professor Bishara, Professor Ta, Professor Bottini, Professor Grillo, and all the ones who helped, because I truly believe that players win games, but teamwork is won by, teamwork is winning championships. Thank you so much, and see you next Saturday.
Thank you, Sergio. Dr. Wasila, would you please introduce our guest of honor? Dr. Wasila, unmute yourself.
Thank you, Professor Genesini, for all your support all the way. And I totally agree with you. There is no conflict in our project. We are communicating together, all together. And we have been by your really ideas and LATAF, or communicating both continents, the Latin America with Africa. It was a great, great idea. Thank you, Sergio. And now the closing words will be delivered by our guest of honor. And I'm really glad and pleased to introduce Professor Rafat Naga. Professor Rafat Naga is one of the grand icons and pioneers of the field in Egypt and the whole region here. Professor of vascular surgery, former chief and founder of the vascular department in Alexandria University, and his prints are remarkable for the development and evolution of our specialty. And the last endeavors and achievement was the summit, which was held in March 2020 in Alexandria. And I think this was the last medical congress all over the world was held. Congratulations for the summit success, Professor Rafat Naga. And now I leave the podium for the closing words of this session for you, Professor Naga. Thank you.
Thank you very much, and I really enjoyed this presentation.
Professor Rafat Nagar, please unmute yourself.
Yes. I enjoyed very much the presentation of Professor Pitaloga and Professor Sergio. I think after 1,000 years of streeting, which started in Cordoba by San Bernardino or something like that, this could be a turning point in the management of varicose vein, keeping the long saphenous vein after this, the evolution of the techniques. And at the end, I would like to thank the board of EVLA, headed by my close friend, Dr. Rashad Bishara, who offered me the great privilege of being the honorary guest of the first webinar of this meeting. Our patient in Africa and the Middle East has been suffered much the malpractice attitude by some of the practitioners who first meet them with leg edema. And I absolutely support this association because it is found by experts, a group of experts who are very expert in the field of venous and lymphatic disease, and are keen to teach the junior vascular surgeon in the area the most sound basis of and the skills of management of this disease. And I enjoyed very much this the group of audit entities, and I congratulate you for this inauguration of your eminent association, Dr. Rashad, Wasida, Ahmed Hassan, and Ahmed Weish. Thank you very much.
Thank you, Dr. Rafat. And finally, I would like to thank again our sponsors, Servier, Biolytic, and Ablate for their sponsorship. And we'll see you again, hopefully next Saturday, same time. Thank you for everyone. Bye-bye.
Bye-bye. Bye-bye. Bye-bye, everyone. Bye-bye.
Thank you.
Bye. See you next Saturday. Saturday, 9/22. Ciao.
Yes.